Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam from Houston, Texas. This is cardiology seminars. We have more than 200 lectures on our YouTube channel, and please do subscribe to our YouTube channel. At the end of this presentation, I'm going to tell you how you can get a copy of our cardiology rotations manual, especially for students, doctors, nurses, and healthcare workers dealing with cardiac patients on a regular basis. The feature presentation is going to be on vasopressors and inotropes for shock treatment. In the previous video, I talked about hypovolemic shock, cardiogenic shock, or obstructive shock in terms of pneumothorax, pulmonary embolus, air embolism, cardiac tamponade, and volume distribution shock. Please watch that video so you get a better understanding of how to treat those conditions with the medications I'm going to be talking about in a minute. I also have a separate video on cardiogenic shock, which talks about things that are very specific to the myocardial damage and cardiogenic shock, and what are the things we need to focus upon when treating patients with cardiogenic shock. So let us begin with the main feature presentation, that is intravenous vasopressors and inotropes for treatment of shock. When we are dealing with shock, first of all, we have to define the etiology of shock. What is causing shock? Is it a problem with the myocardial pump function? Is it a problem related to the vascular system? Is it a problem related to intravascular volume? So there are a number of factors that come into play when we try to choose an appropriate drug for a patient in a shock. For example, in a patient with sepsis, the intravascular volume may be okay, the heart function may be close to normal, but you may be dealing with increased intravascular capacity, third spacing of the fluid, or severe vasodilatation, which is a similar case in patients with neurogenic shock. Whereas if you are dealing with a patient with trauma or bleeding, you are dealing with reduced intravascular volume, where the treatment is totally different compared to when you are dealing with a patient with severe bradycardia and hypotension. There are a number of drugs that are available which work on the contractility of the heart, which works on increasing the vascular resistance, and also there are drugs which improve myocardial function. First of all, we have to determine what kind of an effect we want to get. If we are trying to improve the myocardial contractility and maintain some vasodilatation, then we have a choice of dobutamine or Mildrenone. Whereas if we want to have some inotropic effect, increase contractility and maintain some vasoconstriction because of severe hypotension, then we are talking about norepinephrine, epinephrine, or dopamine in varying dose levels. If left ventricular contractility is not the main problem, and if we do not need vasodilatation, which basically applies to hypertensive patients like systemic hypertension or pulmonary hypertension, then you use nitrates, nitroprusside, or nicerotide. Let's look at vasoconstriction. Hypotension, vasoconstriction. The conditions that we can most commonly think about are neurogenic shock or a septic shock, where the volume status may be okay, where the contractility of the ventricle may be all right, but you're just trying to improve the peripheral vascular resistance and improve the systemic vascular resistance. In that situation, we may be looking at a purely alpha stimulant, alpha-1 stimulant like phenylephrine or vasopressin, which acts on the vasopressin receptors in the blood vessels. Taking this background, let us look at individual drugs and learn something about each one of the drugs that we are going to be using on an ongoing basis throughout our entire practice when we deal with a patient with shock, be it cardiogenic, neurogenic, or be it related to sepsis or volume depletion. Let us start off with norepinephrine. Norepinephrine, as you know, has a predominantly alpha-1 agonist effect. It also has some beta-1 effect. It is indicated for patients with hypotension related to volume loss. It's also indicated for patients with septic shock, cardiogenic shock, and people with hypotension related to any other cause. It causes vasoconstriction. It increases cardiac output. The starting dose is 0.01 microgram per kg per minute. The dose range is between 0.1 to 0.15. It is supposed to be 0.01 to 0.15 micrograms per kg per minute. You titrate them anywhere from 1 to 15 minutes. You need to look for adverse effects like arrhythmias, tissue necrosis because of severe vasoconstriction, ischemia, and tachycardia. Epinephrine is very similar to norepinephrine, except it has a little more beta activity in terms of beta 1 and beta 2 stimulation and less alpha stimulation compared to norepinephrine. The indications are very similar to what we use when we use norepinephrine, and it causes vasoconstriction, increases cardiac output, and because of the beta stimulation, it may cause some venodilatation. That's reducing some venous return. The dosages are 0.01 microgram per kg per minute. The dose range is 0.1 to 0.5 micrograms per kg per minute, and the titration is similar to that of norepinephrine, and we see a sort of a similar side effects from this drug. The next class of drugs we are going to look at are phenylephrine, which is a pure alpha stimulant. It has no effect on the myocardium, and it has no effect on the volume. Mainly it stimulates the alpha receptors in the arteriolar system, thus increasing the vasomotor tone, thus increasing the systemic vascular resistance and improving the blood pressure. It's used in cardiogenic shock, but more often in patients with septic shock or anaphylactic shock or neurogenic shock. Causes vasoconstriction. The dose range is 40 to 200 micrograms per minute. You start off with 40 micrograms and you titrate them at 1 to 15 minute intervals. Again, it can cause tissue necrosis. This could be reflex tachycardia, and it can also cause ischemia. Vasopressin is recommended for septic shock and anaphylactic shock. It acts on vasopressin receptor 1. It increases the systemic vascular resistance, and the dose here is 0.01 to 0.07 units per minute, and the initial dose is 0.03 units per minute. There's no need for titration, and if you need to titrate, you do it every 30 to 60 minutes. It causes cardiac ischemia. It also causes mesenteric ischemia and arrhythmias. Now let's look at a third group of drugs that improve the cardiac function. So they are predominantly used in patients with cardiogenic shock, along with some of the other agents I already talked about if you want to get some vasoconstriction on top of that. Let's talk about dobutamine, which is most often used in patients with heart failure and in congestive heart failure, and also in cardiogenic shock. It's also used in sepsis-related myocardial dysfunction. It predominantly stimulates beta 1 and beta 2 receptors. It improves contractility, causes some vasodilatation, and it may cause mild hypotension. The starting dose is 2 micrograms per minute. Then you titrate it between 2 to 20 micrograms per kg per minute. Titrate anywhere from 1 to 15 minutes. Some of the side effects would be arrhythmias, PVCs, which are very common, hypotension, and hypokalemia. Dopamine has varying effects depending upon the level at which the concentration at which the dopamine is infused. Using a low dose dopamine, like 5 micrograms per kg per minute, we get improved perfusion, renal vasodilatation, leading to improved renal function. But as we go about 10 micrograms per kg per minute, obviously it's going to cause vasoconstriction, used in septic shock and has also been used in cardiogenic shock. Again, they are prone to same side effects like cardiac ischemia, arrhythmias, and tissue necrosis at the site of the IV infusion. Mildrenone is an inotropic agent which is used predominantly in patients with chronic heart failure. It acts through the cyclic AMP or phosphodiesterase 4 pathway. It increases SVO2. It increases central venous pressure, and it increases systemic vascular resistance. Some other side effects of Mildrenone would be hypotension, nausea, and arrhythmia. The dose is 0.125 to 0.5 micrograms per kg per minute. Mildrenone has been shown to improve cardiac output, improve patient symptoms, and also improve quality of life when used intermittently in patients with refractory heart failure. And here's a different chart looking at the same things, but by looking at how significantly they act on either the alpha or the beta receptors. Is one drug here which I'm going to be talking about, isoproterenol, which is isoprel, a beta stimulant, and also causes some hypotension. And this is predominantly used in patients with severe bradycardia or complete heart block as a bridge gap before they can get their temporary pacemaker or permanent pacemaker, because we have covered all the rest of the drugs. So ladies and gentlemen, this is a quick review of intravenous vasopressors, inotropes, and chronotropes in managing patients with various types of shock, and particularly cardiogenic shock. If you would like to get a copy of my book, Cardiology Rotations Manual, please send me an email at drniknikam@gmail.com. This cardiology seminar presentation has been brought to you by N Media, and I would like you to please do subscribe to our YouTube channel, and we will see you in the next video.